All right, thanks. Okay, great. Thanks, Peter. So welcome everyone to our Zoom sessions for the Royal. A bit out of sync today because Peter is very busy in Tasmania on Thursdays. So without further ado, I'd like to introduce you to Dr. Peter Dargaville, and I'm glad I asked what his official title was. He's the Professorial Research Fellow at the Menzies University of Tasmania and a staff specialist at the Royal Hobart Hospital. Is that it?
That's
Is that
it.
it? Okay, all right. So you guys all know Peter from his amazing work on the less mess study, where he used surfactants and lavage for meconium aspiration syndrome, and recently in the Optimist trial. So we might get you back to talk about the updates for that, Peter. But for now, what he will be speaking on is something very novel to us in our neonatal ICU, how we can take away the human factor from, delivering oxygen to preterm babies using his wonderful technology. This talk is recorded, and with Peter's permission, we'll post it onto our social media sites and to our UNSW website. If you have any questions, please feel free to put it in the chat pane, and Peter will answer that at the end. But if you're really desperate, raise the hand with the hand icon on the bottom, and he'll pause everything and attend to you. So without further ado, Peter, the floor's yours. Thank you.
Thank you very much, Julie. It's a great pleasure to be part of this session, and I'm sorry it has to be on a Tuesday rather than a Thursday afternoon when my time is spent on the tennis court in the early evening.
No, that's okay. Priorities. Yeah, that's okay.
Cheers, I appreciate it. I'm going to share my screen now. And I'm hoping everyone can see that. And
yeah,
I'll now
thank you.
Go to slide view, and I'm hoping everybody can see that. And Julie suggested a title of Taking the Guesswork Out of Oxygen Titration. And I don't know that you necessarily say that clinicians would call their work in controlling oxygen therapy guesswork. So I thought it'd be better just to call it automation or automating oxygen therapy. What do we know now, and what are our future challenges? I've got some disclosures there relevant to this talk, and they're shown in red: a consultancy with SLE, which is a ventilator company, a patent in a number of countries, including the US, for a method and system for automated control of oxygen, and a commercialisation agreement that we've struck with SLE, between SLE and UTAS, with the RHH UTAS algorithm and device now embedded in an SLE ventilator. So what I thought I'd talk about, I thought it would be good to go over the rationale for automation of oxygen therapy in preterm infants very briefly, and the approach to automation. Some of you may have heard me talk about these things before, but they do serve as the foundation for what comes next, and that is to discuss the current evidence, both in the NICU and in the delivery room, and we will focus on the delivery room a fair bit in this talk. And then I'm just going to highlight 3 future challenges, some practical issues and problems to be solved, what we might be able to do with individualisation of performance of algorithm function, in particular preterm babies, and its application in low resource settings. The rationale is very simple. We know SpO2 is prone to rapid, repeated and prolonged deviations, and we see it all the time playing out in our NICUs. What we know is, despite the best efforts of the clinicians at the bedside, manual control of FiO2 struggles to keep SpO2 in the target range, and there's been quite a lot of work done on that by James Hagedorn in the AVIOX study, by our group here in Hobart with Kathleen Lim as the first author. And generally, it's hard to keep the SpO2 in the target range even 50% of the time. And in many studies, it was a whole lot lower than that. And combine that with the fact that both hypoxia and hyperoxia have known clinical effects, and we have a very strong rationale to try to do better and to automate the process of oxygen titration. And in terms of the adverse effects of hypoxia and hyperoxia, what we think we know goes as follows. We think that there's some sort of ideal SpO2 range, and of course we've all participated in and are aware of the clinical trials of the NEAPROM collaboration that have looked at different target ranges. But let's suppose we know that there is some sort of ideal target range for a preterm infant. Below that range, it has been seen that hypoxia or relative hypoxia increases the risk of mortality and of necrotizing enterocolitis, and hypoxic episodes are known to increase the risk both of retinopathy and adverse neurodevelopmental outcome. On the other side of the ledger, hyperoxia is clearly associated with an increased risk of retinopathy and probably also of bronchopulmonary dysplasia, and hyperoxic episodes have been strongly linked to an increased risk of retinopathy. And so what we're now then forced to consider is whether we can do better than the current approach of manual control of FiO2, where the bedside staff receive the SpO2 input plus a measured FiO2 that they're aware of, and then compute and actuate a desired output using a very complex supercomputer inside the brain of every bedside clinician. And so what we would then suggest is that we could impose or introduce an integrated circuit there to do the job of the moment-by-moment adjustments to desired FiO2, but in no way to supplant the clinical acumen of the bedside staff, who we would say are still in charge of oxygen titration, but don't have that as a repetitive manual task that they have to do second by second, minute by minute, hour by hour, and they can just keep more of an eye on other things as well as the oxygenation of the input of their baby. And in this sense, we really are reliving what was described in Čapek's play as a robot, which is a unintelligent creature able to perform forced labour or repetitive manual tasks. And that's exactly the intent of our first automated oxygen control systems, is to do no more than perform a repetitive manual task of FiO2 adjustment. The basics of automated oxygen control are stated here. So we have an input coming in, and in this case, it's an SpO2 input coming in from an oximeter to a control device. And it can come in or does come in at regular intervals, and those intervals can be up to 1 second. And that control device holds a set of computational instructions, which is what we call an algorithm. And the algorithm takes the inputs past and present, compares the SpO2 input with the desired set point, which is usually the midpoint of the target range, and then determines an FiO2 response, a change or no change from the current value that's computed and then is automatically actuated, and that's the output. So far, so good. There are a lot of contemporary control algorithms, and there are essentially 5 that are available in contemporary ventilators that units whose staff are online here today may be using. There's also the IntelO2 algorithm has been incorporated into the VaporTherm device, but I'm not sure that that's something that would be available in units that predominantly look after preterm babies. And the various names of these algorithms are shown here. Our algorithm in the SLE device is called the Oxygenie. And they are of different types, these algorithms, and time precludes me going into this in great detail, but needless to say that they fall into 2 really opposing methods of development. The first rule-based algorithms are the ones where we presuppose that clinicians should be able to write a set of instructions to tell a device what to do. And the second, using proportional integral derivative control, says there's no way clinicians would be able to write that set of instructions to cope with every situation. And why don't we just use a standard engineering approach very similar to that used in cruise control and so many other automated systems to control this system of oxygenation. And finally, there on the right, you can see the respiratory support devices into which these algorithms have been embedded. But we're nowhere near the first of this game. I know you won't be able to read the text of this patent document. This is from 1947, and it was from Harry Kirschbaum, a Chicagoan obstetrician who first proposed a method and apparatus for controlling the oxygenation system of a living human. And this algorithm, this patent in 1947 heralded many things that were then to follow, including the method of oximetry, which at that stage wasn't really a thing. We, over the years, as we've come into this field, have identified what we believe are the optimal features of an automated oxygen controller, and that it would involve an algorithm that is responsive, and that means able to make a measured and tempered response to SpO2 deviations in a system with a 30-second time lag. And that's been the reason why many groups have chosen a clinician approach where you make a change and then wait for the response. But that's not at all what an engineering algorithm will do. It will continue to make changes by continuing to monitor the SpO2 inputs that are coming. And so it is possible to be continuing to make FiO2 adjustments even while you're waiting for prior ones to have their effect. The second thing that we could see that needed to happen with an algorithm is it needed to be able to be adaptive. And that means to the variation in gain, which is the step response in SpO2 that you would get for any given step response in FiO2. And we know from work that we've done that this changes with the severity of lung disease. In other words, a baby with bad lung disease needs more of an FiO2 adjustment to bring about the same proportional change in SpO2 compared with one with good lungs. And this needs to be taken into account in the design of an algorithm. We'd also like our algorithm to be intuitive. First of all, just simply to take account of the nonlinear SpO2-PaO2 relationship and to be able to recognise and cope with missing or invalid SpO2 signal. But ultimately, we'd be thinking that this intuition could become intelligence, and that maybe such algorithms will be able to analyse the performance in real time and auto-tune. We're not there yet. We'd also hope our algorithms could be receptive to other inputs than just SpO2, for example, detection of apnea or loss of CPAP circuit pressure or tidal volume. Again, we're not there yet with these in clinical practice. And we ideally would have an algorithm that was attractive for staff in NICUs worldwide, including in the developing world. And my green ticks and red crosses show where I think we're up to with enacting these optimal features in existing algorithms. So we've still got some way to go with the analysis of performance and auto-tuning the inclusion of other inputs and the application throughout our world. I will just briefly touch on proportional integral derivative control because it is a very elegant system for controlling any process, including a biological system. And it's the form that's used for the VDL 1.1 algorithm that has become Oxygenie. Essentially, at every second, every time the algorithm computational loop is iterating, an error is calculated where the current SpO2 value the midpoint of the SpO2 target range is subtracted from the current SpO2 value to give an error. And then three terms are calculated. The first is the proportional term, which is the error times its coefficient. The second is the integral term, which is the accumulated past errors times its coefficient. And the derivative term is the recent SpO2 slope times its coefficient. And so that's looking at the current, past, and future behaviour of SpO2. And from that, calculating a delta FiO2, a change in FiO2 to be made from the sum of those three terms. And the output FiO2 is the delta FiO2 added on to a reference value, a reference FiO2, which is a reflection of the current baseline oxygen requirement. So essentially all that's doing is asking the question, what change should we now make, knowing what the current reference FiO2 is, what the current baseline oxygen requirement is, what should be the next change in FiO2 in this current iteration of the loop. And for VDL 1.1, the delta FiO2 is capped at plus or minus 40%, which does allow plenty of leeway in the function of the algorithm in turning the oxygen up and down. And the algorithm is enhanced and adapted for the biological system under control, and the reference FiO2 is periodically updated. I think it's worth diagrammatically showing you how PID works. It's not that complicated really when you break it down to its component parts. Here's a good example of SpO2 deviating out of the target range, shown as the grey bar, with the SpO2 now in the hypoxic region. And the first response that is made, if we look here at the PID terms shown here in this second panel, the P term responds immediately when there's an SpO2 deviation, as it's programmed to do. And as a result of that increase in the P term, the delta FiO2 ramps up, and so we have an initial rise in FiO2 in response to this hypoxic episode. And then what now needs to happen is that the algorithm has to be able to cope with what's called steady state error. And so we've made an initial change to FiO2, but now the SpO2 is stable but below the target range. And the P term won't be now changing. And so we'll be relying on the I term, showing accumulated past errors that will continue to ramp up. And as a result, the FiO2 will continue to ramp up to resolve this hypoxic event. And so that's the value of that I term. And it's very important in PID control to have that term properly tuned. And as a result of that, the SpO2 is restored into the target range to some degree, both with manual control and with automated control. Overshoot is inevitable. And this is why we need to have our FiO2 adjustments being quite tempered with automated control to avoid overshoot and then the potential for oscillation that I'll mention later. And that's why tuning the coefficients for the PI and D terms is very important. As you can see here, we've just overshot slightly, and we can quickly get back down into the target range of SpO2 as the integral term reduces back to zero, and the proportional term now is less than zero, and the FiO2 as a result of those goes back down to the baseline. So that in a nutshell is what we're expecting from the PID approach, and that applies to so many systems universally, as I've said. Now I'm going to turn to the clinical effects of automated oxygen control and discuss what we know in the NICU and also in the delivery room. And in the NICU, we've got quite a lot of evidence that's now accumulated, and those listening can be pointed to the Early Human Development Review that we just did that has this image or this figure in it of the performance of automated control compared with manual control using a whole range of different algorithms, a whole range of different SpO2 target ranges, and of course, a range of different gestation ranges and birth weights for the babies involved. But having said that, uniformly, automated oxygen control seems to be able to perform better than manual control, even though for almost all the studies the number of manual oxygen control adjustments required during the automated control period is a whole lot lower than during standard manual control. In other words, the devices are, up to a point, acting like good robots and controlling this system with less human intervention than would otherwise be required. I'm not going to go through these studies individually. The white bars show automated control and the black bars manual control. And as I've said, there are a whole range of different settings and conditions that make it difficult to draw too many conclusions between these studies, other than to say overall, they do seem to suggest a benefit of automated control in targeting the time in the SpO2 target range. And we're working now on a Cochrane review, of which I'm a part, that will summarise this evidence using the data from the randomised crossover studies, which doesn't include all of these. And I've got a few panels from the upcoming Cochrane review as a taster. I know you won't be able to see the names of the individual studies, but you'll be able to see the black diamond summarising the evidence in this forest plot. And in this one, which looks at time in target range in randomised crossover design studies, where the right-hand side of the forest plot favours automated oxygen delivery, we can see that there's about a 10 or 11% increase in time in target range associated with the use of automated rather than manual control in these crossover studies. The other two important panels in the Cochrane review, time above target range, where here now the black diamond being on the left side favours automated oxygen delivery. And we can see that in very large part, the algorithms are actually pretty good at keeping the SpO2 out of this range. In other words, away from the hyperoxemic zone that we know is prominent under conditions of manual control. So algorithms should be able to do this quite well. On the other hand, sometimes the cost of keeping babies out of the hyperoxemic zone is hypoxemia. And this is now the panel in the Cochrane review for time below target range. And here still the left panel favours automated oxygen delivery. And in this panel, we've divided up into studies that are looking at babies invasively supported on ventilators versus non-invasively supported. And for the 3 studies where the automated control has been put to use in babies on invasive support, we can see we're not actually getting an improvement in relation to time below target range in 2 of those studies. And in fact, overall, the effect is for more time rather than less with the SpO2 below target range. For the babies on non-invasive support, the summary result did favour the use of an automated control system. And of course, these are just short-lived crossover studies, and many of them are up to 24 hours in duration. This doesn't really tell us a lot about what the impact of automated control is going to be over a long period of time. I will, though, spend a little bit of time talking about the study we did using the Oxygenie, and look particularly at this question of whether there's a trade-off between hyperoxemia time and hypoxemia time. Our study is not included in the Cochrane review because it wasn't a randomised crossover study. We instead chose a design of having a 24-hour period of automated control nested between 2 12-hour manual control periods with a washout of 30 minutes. And throughout the study, we asked our staff to take a routine approach to oxygen targeting with an SpO2 targeting a target range of 90 to 94%, with alarms at 89 and 96, and manual override of the controller allowed by the staff at any time. And heading straight to the results of this study, we had 35 infants included and a total of 60 studies with 1,400 hours of automated control being examined or scrutinised in this study. And these were babies with a median gestation at birth of around 27 weeks, who were studied at around 2 weeks of age. And here's the histogram, and I think most people would be familiar with seeing these histograms showing the proportion of time at each SpO2 level. And here is the section of the histogram in the target band or the target range indicated with the T. And like most histograms in relation to the use of manual control, they tend to be skewed with higher values favoured, and hence values outside and above the target range favoured in manual control. And this is a uniform finding and observation that's been made over many years in relation to manual SpO2 targeting. And the algorithm does it differently and has a fairly non-skewed histogram, with the modal value being 92, the midpoint of the target range. And what we can see here is that both time in hyperoxemia and in hypoxemia are reduced with the looking at the pooled data with the VDL 1.1 algorithm in action. And when we look at those data expressed on a per study basis in the 60 studies that were performed, the time in target range increased by around 23%, 58 to 81% in this study. And importantly, in particular, in relation to the observations that have been made in relation to some algorithms trading off hyperoxemia for hypoxemia, what we saw in our study was that time in both hypoxemic ranges and hyperoxemic ranges was reduced, and in the case of hyperoxemic ranges, substantially reduced with the use of the VDL 1.1 algorithm. And perhaps even more important was the effect on episodes, long-lasting episodes, shown here for hypoxia and hyperoxia, 30 seconds and 60 seconds. And in manual control, those episodes occur not infrequently and were much reduced with the automated control algorithm. Another very important aspect of understanding algorithm function is for us to know whether we think that a particular algorithm is actually going to benefit every baby. And you can argue pretty strongly that the use of a robot shouldn't cause harm. And we should be trying to avoid a situation where robotic control of any system, be it tidal volume, thermoregulation, or automated titration of oxygen therapy, shouldn't be causing harm. And so we've been very careful to look at this in our studies, and would urge everybody who's doing this work to do this. And we saw that there was either equal or better targeting for every single individual with automated oxygen control compared with manual control in this study. Just mention now the first of what I hope are more studies that actually compare different algorithms head to head. And this study was done by a chap called Hilke Salverda in the Leiden University Medical Center, Ian Pass being the lead researcher. And this was a crossover study of the Oxygenie algorithm in the SLE 6000 ventilator versus the Clio algorithm in the Avia ventilator. They're not easy studies to do because you have to then wheel in one ventilator and swap a baby over from one to the other in randomized sequence. But yet they give potentially much more information than any other form of scrutiny of algorithm function. In this particular study, the target range was 91 to 95 or above 95 if the babies were in room air. And we'll just focus on a few rows here of this panel that's in his publication. The Oxygenie was able to keep the SpO2 in the target range around 11% more of the time compared with Clio. But there was, to some degree, a little bit of trade-off because the time below target range was somewhat increased with Oxygenie compared with Clio. But on the other hand, the amount of time above the target range was markedly reduced. with the Oxygenie compared to the Clio algorithm. We didn't quite know what to expect when these two algorithms went head to head, and these are the findings that we have. And you can see the various proportions in the different hypoxemic ranges and the hyperoxemic ranges. The other work that Hilke Salvert has done is in relation to the clinical impact after, in essence, a before and after implementation study. And the first one that's published is between the time at LUMC, Leiden Medical Centre, when there was no automated control, to where there was automated control with the Clio algorithm in the Avea ventilator. And this study of the clinical impact, as you can see here, showed there was no clear impact actually of the after the implementation of the Clio algorithm. And further studies are now being done in relation to what the clinical impact has been of the use of the Oxygenie algorithm in the SLE 6000, which has now become their ventilator routinely used at LUMC. Of course, the only real way of getting a full understanding of the clinical effects of automated oxygen control will be by randomised trial evidence, one would think. And there is a trial, as far as I know, there's only one that's going at the moment, and I'd be interested if anyone knows of any others that have started. But the FIO2C trial has been going now for a number of years, I think about 4 years. It's a large randomised control trial of automated versus manual oxygen control with Axel Franz and Christian Poets from Tübingen leading it. And they're looking at whether automated control can improve heart outcomes in preterm infants less than 28 weeks. And the number to be recruited is very large, 2,200. It's a very pragmatic trial in design. They're using any automated control device applied for as much of the time as possible. They're not actually measuring the SpO2 targeting in the subjects, or at least not in all of them. And this is now recruiting, and as of August last year, there were 570 infants in that study. So that evidence or that trial result is still some years away. Now I'd like to turn to the delivery room and present some results of a study that we've just recently had published on the first go at automating oxygen titration in the delivery room, which I would suggest is a very hard setting in which to apply robotics for a whole lot of reasons. And thanks to Julie for sending this recent photo of the Royal Hospital for Women delivery suites, and she also sent some captions of what she imagined would be said here. So the attendant there saying, this baby's 25 weeks, better ask Julie Oy what FiO2 we should start off with. I think she's probably better placed than most people to be able to give us some info there. Another attendant suggests, put this oximeter probe on, that should help. And then another said, doubt anyone will have time to adjust the oxygen. And I guess that's my way of introducing the difficulties of manual FiO2 targeting in the delivery room. It is partly about the personnel and about all the other tasks they have to attend to at the same time as trying to control SpO2. So can we really target SpO2 in the delivery room? Well, what we know is, of course, that there are SpO2 nomograms that have been developed and are now used in various forms for delivery room care in preterm infants. The targeting of the SpO2 ranges is known now, however, to be poor. And Jack Raby in the RAW study showed that, where there was only about 20% time was the best in the three groups. In the RAW study, the group from San Diego with Gandhi as the first author, and I'll show a panel from this, also could only at best get 50% time in the target range in their study, and a group from Rotterdam and the Women's Hospital group in Melbourne also had less than 50% time in the target range in their studies. So we've got a real potential here to be able to do better. But as I said, applying a robot in this circumstance might be difficult. The group from San Diego simply tried to answer the question, if we just had a display of the incoming SpO2 values and FiO2 values, would that be better? And they developed the Transitional Oxygen Tracking System, or TOTS, and many of you will know this study, and essentially they found that having a monitor available for people to look at improved time in the target range from 37 to 52%, which is not bad. In our study, we had a transition tracker, as I'll show you, but we didn't make it available to clinicians, at least not in this first study that we did, but I certainly think it's not an unreasonable thing to do to help them pitch their SpO2 in the right range. So Senol Jali led this study, which went for around 3 years in all. And the design of it, as shown here, was to look at preterm infants less than 32 weeks with prenatal consent. And our intervention group were those where the FiO2 adjustments in the delivery room were made by an automated oxygen controller of the PID type. The comparator group, which came first in time, was to have standard manual control of FiO2 adjustment by clinicians. And the outcome of interest was proportion of time the SpO2 was in the target range, which was the 25th to 75th centile of the dorsal nomogram, or above that if the baby was in room air, and that was over the first 10 minutes after birth. And Sanoj, as I said, did this study, and it was done in 3 stages, where we started off with observation and tracking and recording of standard delivery room management under conditions of manual control of oxygen titration. So there was a researcher in the room, they had a little trolley, and they were collecting the SpO2 and FiO2 data, as well as the airway pressures, so we knew whether the baby was receiving CPAP or positive pressure ventilation at any given moment in time. And then in stage 2, we actually tuned a PID algorithm specifically for the delivery room using abstracted oxygenation data from stage 1, and we've done that in the same way as in our previous work, where we developed the VDL 1.1 algorithm using that sort of simulation. And in stage 3, having tuned the algorithm and embedded it in a device, we then did a feasibility study of automated oxygen control using the tuned algorithm. And in each of the clinical stages, there were 20 infants in the study. They were median gestation around 28 to 29 weeks, and almost all of them were born by caesarean delivery, and all bar one of them was transitioned in our delivery room on CPAP. Here's the transition monitor that we developed, but this was solely for the researchers to be using. It shows the median and 25th and 75th centile of the dorsal nomograms. It also shows down here in a bar whether a baby was receiving no CPAP at all, ambient pressure shown in yellow, green being CPAP, and red being periods of positive pressure ventilation. And in the data we obtained in the manual control arm of this study, first up in our 20 babies, and I think you can imagine what it's like, the range of different circumstances was very great. It ranged from babies who were on CPAP, needing positive pressure at the beginning for a kickstart, and then fully on CPAP thereafter, babies who intermittently needed positive pressure ventilation, yet others who really were reliant on positive pressure ventilation, with a lot of red in this tracker here. And coincident with that, their oxygenation varied enormously one to the next, as I think everyone could guess, with some babies being able to be controlled fairly easily with manual control, achieving 65% of time in the target range here. In some cases, the control was absolutely stellar. The baby had followed the nomograms perfectly with very few oxygenation adjustments. But in yet other cases, despite multiple adjustments by the clinical team, the SpO2 was wandering all over the place with only 41% time in the target range. As I mentioned, we were recording the data obtained, and we abstracted it into values for shunt and for VQ ratio, and we're able to then use that data in a simulation. What we did in simulation was to use multiple permutations of PID coefficients and to use the abstracted data along with FiO2 values to give us SpO2 values, which in this counterfactual simulation were different than the SpO2 values in the original recording. And so what we were able to do was to find out in pooled data which combination of coefficients gave us the best SpO2 targeting. And the parameters we used in the assessment of that were time in the target range, which was double weighted, avoidance of hyperoxemia, avoidance of hypoxemia, FiO2 stability, and SpO2 stability, with these measured as coefficients of variation. And so we developed a radar plot and we weighted each of the parameters 0 to 100 for each of the combinations of coefficients. And we were looking for the radar plot with the largest area. And I'm just going to point out 3 radar plots here. The red one here is the SpO2 targeting measured by these parameters with manual control, so a small area. The one in yellow here is the SpO2 targeting parameters in the area traced out with the algorithm now used for NICU care, the VDL 1.1. And in blue, traced out is the area for the SpO2 targeting parameters for the delivery room algorithm that we developed, which had by far and away the largest area. But one thing it wasn't very good at is keeping the FiO2 stable. In other words, there was quite a wide coefficient of variation of FiO2, which heralded what we found then when we applied the algorithm in clinical practice, is that the FiO2 did bounce around a fair bit. And here's some examples of automated control in the delivery room. We instructed the clinical team, who didn't see the tracker, as I said, that they were to remain in charge and could make overrides of the FiO2 whenever they wished. And apart from one example where the SpO2 didn't actually come to be picked up until around 7 minutes of life for technical reasons, and a few FiO2 adjustments were made, no other baby had any FiO2 adjustments made manually in the automated control infants. And so all the FiO2 changes you can see in these examples are from the algorithm. And the algorithm, as you can see, acted emphatically in cases where the SpO2 was low. Here's an example. SpO2 when first measured is 40% and remains so for about 20 seconds, and the FiO2 quickly ramps up in response. And then when the SpO2 does overshoot, as it does in this instance, the FiO2 comes down. And we can see and perhaps postulate that in this case, the FiO2 response may have been over enthusiastic. And that's something that we are very much looking at in the consideration of where we go next with our algorithm function. The example here in the middle, where the target range time was 99%, shows after the SpO2 is picked up that the starting FiO2 of 30% then alters with the algorithm making adjustments thereafter each second if needed, and keeping the SpO2 well and truly on track in the target range. With yet other instances, particularly in babies who were receiving positive pressure ventilation, like this one was for a good 2.5, nearly 3 minutes. The FiO2 once again can be shown here to bounce around. So we do see a very wide range of responses depending on the circumstances for the individual baby. We pulled the data by here showing the 25th to 75th centile for the SpO2s in the pooled data, shown as the dark grey, and the 10th and 90th centiles shown in the light grey. And we've shown here the comparison between manual oxygen control and automated oxygen control. And what you could see and say is that certainly beyond 5 minutes, that the control is roughly equivalent, maybe slightly better, one could argue, with automated control beyond 5 minutes. And I'll show the per patient data in a moment. The pooled data for FiO2 clearly shows that the algorithm was prepared to do more work with FiO2 than the humans adjusting FiO2 were able to do or wanted to do. And as a result, the values in terms of the spread of FiO2 were a whole lot greater with automated control. Here are the oxygenation outcomes, comparing the manual control group with the automated control group. One baby fell out of the automated control group by virtue of there not being SpO2 data available after the recording was done. And the time in target range didn't differ between the groups. It was numerically higher by 10% in the automated control group, but in our small study, this was not a significant result, nor was the time below the 25th centile different. However, the time above the 75th centile when receiving oxygen was somewhat lower in automated control than in manual control. I'll just point out that the clinicians were trying pretty hard to keep the FiO2 in the target range and made 11 adjustments on average during the 10-minute recording to FiO2. The automated control device made 37 adjustments of 1% or more on average over the first 10 minutes. The mean FiO2, as we saw, was somewhat higher during automated control, and certainly the maximum FiO2 was a whole lot higher. But the final FiO2 for these two groups was very similar, around 30% at the end of the 10 minutes. Our conclusions in relation to automated oxygen titration in the delivery room were that it was feasible, that we needed further studies, we needed to consider tempering the FiO2 response to a degree. We need to do multi-centre studies now in a larger number of infants and start to have a focus on clinical outcomes. Just very quickly going to now address a couple of future challenges and really just point them out rather than try to answer any questions that arise. But there are some practical problems that have to be solved, and it's not so much up to me, but up to everybody who's listening in and looking after babies in their own units. What are you going to do while we're waiting for the RCT evidence to come if you have automated control available to you? What SpO2 target range should be used? And I don't really want to open up that can of worms right now. We do have the problem of using 2 SpO2 probes if you're using a ventilator that takes an SpO2 input but doesn't transmit it to a monitor, a clinical monitor, which might be connected to a central station. And that's something that we are working to address. But of course, it's solved by having your respiratory support device linked to your monitor, as is now becoming increasingly available. And also there's the issue of application in babies on bubble CPAP, where we're not wanting to use a high-tech ventilator at the moment. We don't have a air oxygen blender that has automated control within it. I'll just mention that we are here looking to individualise the performance of automated control. And it, as I said, it should be able to adapt and to measure performance in real time. As I intimated, we wouldn't want robotically controlled oxygen therapy to be worse than manual control, but it is possible it could be. And And we have done a simulation that shows that. Andrew Marshall, a PhD scholar in our group, is working on this sort of engineering stability analysis, where you actually in real time perform fit a transfer function, which is like an exponential equation that then allows you to calculate what the coefficients of the PID control system should be. And then you can examine the stability and robustness of the model with a range of PID coefficients. And what we have seen in our simulation is that there can be a lot of oscillation of FiO2 and hence SpO2 if the algorithm is overpowered. And by a simple change in the coefficient in real time, it might be possible then to reduce the power of the algorithm so it's making less emphatic with FiO2 adjustments. And as a result, the SpO2 may be kept in the target range better. And lastly, we think it's not only possible, but necessary to apply automation of this form in low resource settings. Even though you could argue that it's a high-tech form of respiratory support, it's not at all difficult to imagine and envision that it could be used in a low resource setting. So I'm talking about settings where there are no high-tech ventilators, no access to piped air and oxygen, and in fact, no source of oxygen other than oxygen concentrators. And what we know in those settings from the work that's shown or cited there is that oxygen therapy is now becoming increasingly available. For example, in units in sub-Saharan Africa, oximetry is starting to be used, and simple CPAP machines are becoming available. And our thinking there would be, if oxygen therapy is available and oximetry is available, we have the oxygen delivery, we have the monitoring, why not connect the two with automation and close the loop? Because the one thing that units in the developing world in low resource settings won't have is the same number of staff per patient as we have the luxury of having in most of our neonatal units. And hence, even if the oxygen therapy is there and the oximetry is on, if there isn't anyone immediately available to change the FiO2, if the SpO2 is out of range, then we haven't done the infant a service. And that's where automation can come in. And a PhD scholar in our group, Lachlan McLeod, is working on this and asking this question of, can we apply this technology in low resource settings? I think it'd be very hard to automate this system where babies, two of in a unit in Mongolia, are connected up to a form of wall oxygen with a flow meter. But that's going as a sort of a low flow to them, and we've always thought that would be very difficult to automate in a meaningful way. And on the other hand, there are a number of these quite simple and relatively cheap CPAP systems that have been developed. There's one called the Humani, this one's called the Diamedic, and there's a lot in low resource settings. And what we propose to do is to adapt these to automate the flow of air and oxygen in the case of the Diamedica, to allow automation of oxygen control to be included. And here's an example of the flow meters in this Diamedica machine with our gearing and a servo motor. It allows when we want to make a change, and we'll make a change from 2 to 3 litres, you can see in the video, it ramps up automatically to the 3 litres we're now calling for. And we can do this, and we can do this with a high degree of precision. And so immediately we've got the hardware that allows us to automate the control of oxygen and air to give the FiO2 we want in a low resource setting using this CPAP device. And we're now about to embark on our first study of automated control of oxygen in preterm low birth weight infants on CPAP with a number of collaborators at the Centre for International Child Health at MCRI and also at 2 hospitals in Nigeria in what we're calling the Gondwana project, or the Gondwana collaboration, where we're thinking of the world as one, and that oxygen therapy and the automation of it should be thought in global terms. And with that, I'm going to acknowledge the great work and energy of so many collaborators and co-investigators as part of the group of engineers and medics laboriously investigating neonatal systems. That's the Gremlins, based at UTAS. And I would very much welcome comments and questions at this point. Thank you.
Thanks, Peter. Great talk. And how did you get the pictures of our unit after the renovations?
I thought I might press a few buttons for you, Julie, and I hope you received that in your spirit.
Oh, no, that was a step up of what we have now. All right, okay, so we have questions, and I can see there's a massive one from Kurt, a massive one from Zana. Kishore sent me a question, but William has unmasked himself, so we might go to him first.
Peter, that's really fantastic. And I'm really excited to see that you're including Ibadan in Nigeria, where my father was born in Nigeria. So that's very encouraging. Listen, a couple of things, just a technical one. How many patients in that before or after study in Leiden that you reported with the mortality and the outcomes?
Yeah, look, I think that was about 200 or 240, something like that, William. So it wasn't a very large number of patients.
Okay.
What was done is that the data were collected in a period of time with manual control, and then the number was matched in the automated control echo.
And the second question is really, second is just a response to some of your last slide. I mean, this won't be any surprise to everybody who knows me, but while we're waiting for the randomized control trial evidence, I think one of the best things people can do is join the randomized trials. So there is Julie's running, well, me and Julie are co-chairing the Torpedo 3060 trial, which is open to enrollment. So it's open. We've got a number of centers over in Europe and India joining that. We have, how many is it, Julie, in that study at the moment?
How many babies?
Yeah.
Well, there's one that's as slow as ours, a FiO2C trial, right? So we beat them with 580. So
we have 580 patients, and we're aiming for 1,470 patients. They're under 30 weeks gestation, I think. So anybody who's interested in get in touch with me or Julie, and we'll give you some details about how to join that trial.
Thanks, William.
That includes you, Peter.
Definitely. Thank you.
Is that still possible? Is it still possible that Hobart could join that trial?
Well, we could certainly have a discussion about it. It's certainly, from a technical point of view, feasible at the moment. Depends a little bit on what we do with automated oxygen control in the delivery room from here.
Yeah, I mean, it seems to me that it may be possible to work that into the trial. We've got a study called the promotion study, and I was just thinking about whether the technology that you're pioneering could be part of that study as well. So ongoing discussions.
Okay, Okay, brilliant. Thanks, William. Okay, we'll move on to Kurt, who's unmasked himself as well. His usual complex question, so I won't bother reiterating it. Kurt, over to
my
you.
typing was very off, but Peter, this was great. You know, I've been following this and your progress in this for a while, and we indeed purchased some machines which have it in place. So we had some experience now clinically of how it worked, and initially there was like, "Ooh, what is this?" And then when it actually was used in almost all patients, it gave just a huge benefit, in particularly reduced nursing, you know, repetitive actions on that same patient. I think that is just one of the major benefits, and we'll wait and see how much the long-term benefits will be. I want to point out, you pointed it out already, that in the delivery room there's a set protocol. You do your, you know, saturation probe on the right hand, but after the delivery room, there is either by practice or by a logistic needs, you put the probe somewhere else. And that we had one case where when like, oh, we just didn't realize that we put it, you know, postductal, and the baby had a much higher PaO2 as a result, because we just didn't, I don't know, you should notice it, but we didn't. So what do you suggest for that?
Yeah, in the study that we did in the NICU, published last year, the Santo B study, as we called it, the probe was either pre or postductal. We tried to, and in fact did, as much as we could, look at whether there was a difference pre and postductal. We had a video on each of the babies in that study. It wasn't always so easy to see where the probe was. We didn't think that we could discern a difference in the capacity of the algorithm to target the SpO2 range, pre and postductal. There are a few issues though. If you have a preductal probe going to the monitor and a postductal probe going to the ventilator, you might end up with PaO2s or SpO2 values, and hence PaO2s, preductal, that are higher than what you really would like. And so, yeah, there are lots of considerations like that. But at the moment, you couldn't say that automated control can only be used on a preductal probe. Because for most babies, there won't be a massive pre-postductal difference. Obviously, you could make the case if they've got evidence for pulmonary hypertension that you wouldn't target a postductal PaO2 or postductal SpO2.
Okay, thanks, Peter. Not sure whether Azana is online. Azana, if you want to ask a question about swings in FiO2.
Yeah, hi everybody. Yeah, that was really great, Prof. Dargaville. I mean, it was really great, Peter. I'd like to find out about the points that you mentioned about FiO2 stability. Do you think that swings in the FiO2 rather than hyperoxemia or hypoxemia actually can cause the damage rather than the state of hyperoxia itself?
Yeah, that's a very good question, and one that's been running through my mind for a while. I remember reading a study that I think Jane Pillow was either lead author on, or certainly was a senior author on, looking at the vulnerability of pulmonary epithelium to high oxygen. And so what we'd certainly hope is that automated oxygen control didn't increase the overall burden of exposure to oxygen. But as you've said, even short-lived swings to high levels might be disadvantageous. And for that reason, for our next delivery sperm study, we are thinking that we'll need to temper the FiO2 response. And of course, that might in turn lead to a slight reduction in time in target range. I guess that's yet to be determined. But yeah, we do think it's important that there not be swings to or peaks of FiO2 to an unnecessary high level. I certainly agree that's an important consideration.
Okay. Thank you. We got a question from Kishore from India, who's probably too shy to ask you himself. Where do you buy this from?
Well, as I pointed out in the table, there are 5 commercially available ventilators that have automated oxygen control technology within them. I'd have to say the Arvia ventilator with Clio inside it is probably got to the point of no longer being available, but there are still 4 others. And without being seen to be biased, I won't go any further with that. There are a number of different machines available.
How much? He said. Next question.
Well, I can only answer that based on what I know with our agreements with SLE, a few thousand extra to have that inside the ventilator is what I think I know.
Okay, I'll feed it back to him by WhatsApp. But if you guys have any more questions, maybe they could contact you directly. We're out of time. No other questions on the chat box. So thank you very much, Peter. I hope the run up to PAS goes well, and hopefully we'll meet there.
We love it.
Bye, everyone.